Thank you, Chad. Thanks, everybody, for letting me be here today. I want a special thanks to Kevin Harrison for inviting me to speak today. It's kind of surreal being here back after about a year being gone. I spent almost a decade here, and a lot of familiar faces, and it's really nice to be back home. So I thought what I would try to do today is just kind of give a broad overview about what structural heart disease and transcatheter valve treatment is today, and I think what we have to look forward to in the next 5 years. And a lot of the later discussion and talks this afternoon and throughout the morning, I think we'll probably delve into some of the topics in a little bit more detail. So, being back at Duke, I thought, how do you start off a talk at a place where so many of your mentors and things grew up, and you learned everything from all of these awesome people? So I say WWBD, and I know Van already knows what I'm talking about. So what would Bayshore do to start a talk? So, I thought back to all the wonderful lectures that Dr. Bayshore gave throughout my training here. And, I figured he'd probably start off with something like this, his favorite YouTube video of the penguin getting slapped into the ice. But, so a little humor to start the morning. And so, by way of outline, I think what I'll try to give an overview of is what exactly is structural heart disease. A lot of focus in the last 5 years on this topic and what exactly it means, and some of the epidemiology of valvular heart disease, what a structural heart disease program, a comprehensive structural heart disease program is doing today, and what I think they'll be doing 5 years from now, and a little bit at the end of what my experience has been in New Mexico. So I thought this was an interesting article, an editorial from Dr. DeMaria, former editor of JACC, a couple years ago, that he was all the information about structural heart disease. So what exactly is structural heart disease? And it's hard to read there what the imprint is, but I think it is unfortunate that the nomenclature chosen for this category of cardiovascular disorders and their therapy has involved the word structural. The concept engendered by the term and the reality of cardiac pathology are inconsistent, and this has led to some degree of confusion. I thought that was kind of interesting. Clearly he doesn't do structural heart procedures, and that's why he has this philosophy on it. But unfortunately, the term is stuck and it's here to stay, and I think it's a great all-encompassing term for what we do. So from a broader general sense, structural heart disease, I think, refers to any structural or functional abnormality of the heart which impairs normal functioning, whether it's a congenital process or something acquired, valvular heart disease, degenerative valvular heart disease, rheumatic heart disease, anything that leads to structural abnormalities or functioning. And I think more recently what it's come to encompass is non-coronary cardiovascular disease processes and the related interventions. As the last 5 to 10 years have proven, a lot of the growth in cardiovascular care has been in coming up with less invasive ways to treat valvular heart disease and other similar problems. So this is a structural heart-centric, I think, way to look at cardiovascular care, but I think the advantage is it really helps us encompass a lot of different fields. So within structural heart disease, you have a lot of work with advanced heart failure, mechanical circulatory support, percutaneous LVADs and such. Of course, congenital heart disease and pediatric cardiology, learning how to treat advanced congenital heart disease percutaneously with less invasive options. Left atrial appendage occlusion has also allowed us to work with our EP colleagues more. And then complex coronary disease, because a lot of the patients that we see with structural heart disease, aortic stenosis and other things, have a lot of coexisting coronary disease. So trying to come up with ways on how best to treat these patients is really important and key. And I think structural heart disease really helps focus and kind of have these different areas work together. The real thing that I think has been a great advantage with structural heart disease is this incorporation of the heart team. Probably at the start of my training here, I don't think this is a very common thing. By the end of my training, this is a uniform thing, and I think we have TAVR to really thank for the introduction of the heart team and incorporation and getting all of these specialties together to really work with one another and complement each other's skill sets and talents. And you have cardiology, cardiothoracic surgery, pediatric cardiology, all of our advanced imaging, our radiologists who have been key in providing our pre- and intra-procedural planning, similarly with our echocardiographers and intra-procedural transesophageal imaging has been instrumental in some of the procedures that we do percutaneously, and really is a driving force for being able to have a successful procedure or not. Similarly, working closely with our anesthesiologists. Our CT surgery colleagues are very used to working with them, but for cardiologists, it's definitely a more new thing that we're getting used to. And clinical coordinators probably should be at the top of this list because they're really the linchpin, I think, for a successful structural heart disease program. Having valve clinic coordinators and TAVR coordinators and MitraClip coordinators that are reliable and trustworthy, and they're the ones that really do all the work. And I think they really should probably have most of the accolades that these programs get. And of course, research team members. I think Duke is a place where this is really exemplifies how to grow a successful program. Is all of the studies that have that Duke enrolls in. I think that's what the research team is key in making sure that a successful structural heart disease program, top-notch program, stays on the map. So this is older data, about 10 years ago, but I think it still holds true, and even more so as the population continues to age. But I mean, valvular heart disease is really a process of the aging and process of the elderly. Over the age of 75, the prevalence of mitral valve disease and aortic valve disease really starts to shoot up, and you can see, and I think the growth of structural heart disease programs in this country and treatments for this really mirrors the epidemiology of the disease process itself. This is another study, once again, about 13 years old or so, but similarly just says, I mean, the proportion of patients with aortic stenosis and mitral valve regurgitation are really the elderly, over 70. So coming up with better ways to treat these patients who have other coexisting comorbidities that may not be best well suited by traditional open heart surgery, I think has been important and advantageous to the care of our patients. And this was the other thing that came to fact is, close to 45% of patients with aortic stenosis prior to really the introduction of TAVR weren't offered on any treatment. And similarly, and probably still more so with mitral valve regurgitation, over 60% of people are not offered any treatment. And I think TAVR has been great because it's allowed people who had no other options and weren't getting treated before an opportunity to now have treatment. Mitral valve, we're still sort of, I think, in the early phases of technology with transcatheter mitral valve treatment, but it's also going to have a huge impact on the treatment of patients with mitral valve regurgitation. So I thought how I'd start off is just give an overview, I think, of what a structural heart program today looks like and what the opportunities for treatment are and what we offer our patients today. So a list. There's so many options for what we can do. TAVR, of course, being the first thing. Transcatheter mitral valve replacement and repair. Valve-in-valve procedures, so people who have had previously implanted surgical prostheses that are now failed in either the aortic position, mitral position, and even tricuspid position. Some hybrid surgical valves, the sutureless valves like the Edwards Intuity and the Percival valve. Maybe these are things that have a role in the future if you're doing some, a CABG and an AVR. Maybe it helps decrease your pump time and things like that in the future. So. Left atrial appendage occlusion, once again, to be able to offer patients who aren't great candidates for long-term oral anticoagulation an alternative while maintaining the same stroke reduction. And congenital heart disease, so simply things like ASD and PFO, VSD and PDA that have been uniformly treated now percutaneously for many years. Now even more complex things, patients who've had prior tetralogy of Fallot repair and other RV outflow tract and pulmonic insufficiency now have transcatheter ways to be able to treat their valvular heart disease. So a long list of things, and there are other things that aren't even on this list, but you see all the growth in the last, I think, 10 years in cardiology and cardiothoracic surgery growing these ways to treat these patients. So I'll start off with TAVR, high and extreme risk. I think it's become the standard of care for taking care of patients with degenerative aortic stenosis in these two categories of patients. So the SAPIEN 3 valve, commercially approved about a year ago for the treatment of patients who are high and inoperable risk for aortic stenosis for traditional surgical aortic valve replacement. 14 French delivery system for 3 of the available sizes, 16 French for the 29 millimeter valve. Treats a wide range of annuluses and has the advantage of having this sealing skirt that helped reduce the paravalvular leak rates with TAVR tremendously from the earlier generation SAPIEN systems. And I think it's been a nice advantage to offer patients small delivery catheter size as well as good rates of paravalvular leak. And the valve positioning system was redesigned from the earlier generation SAPIEN systems to help improve stability during deployment, and it's been a real advantage. So just to quickly summarize the data that led to its approval, really good numbers. I mean, this is a high and inoperable cohort risk, and you have 85% survival at 1 year. I mean, pretty tremendous outcomes with this valve system. The 30-day endpoints were really good. All-cause mortality at 30-day was less than 2% for a high-risk inoperable cohort. I mean, really tremendous results with this transcatheter valve, which I think tends to show why people did so well, or why people continue to do so well with this technology. Stroke, I mean, you compare these stroke rates to the first generation Sapien systems, significantly lower. New permanent pacemaker, 13%. No valve thrombosis. Really good rates of outcomes with this valve system. And you compare Sapien 3 to some of the earlier generation Sapien systems, I think this shows that the technology that Edwards put into redesigning this valve system improved the rates of paravalvular leak significantly. So no cases of severe PVL at 30 days or a year. Most cases, almost 70% of cases with none or trace PVL at a year, only 30% mild. And unlike the initial partner data, with the Sapien 3 data, there wasn't a 1-year mortality correlation with or association even with mild PVL in this group. So, for a high risk and inoperable group, mild, if you're getting almost 98% of your outcomes, having tremendous results with no significant PVL that has a long-term outcome or impact on long-term morbidity or mortality, I think speaks volumes for the technology and the advancement over the last 5 years. The other commercially available device, the CoreValve Evolut R, also similarly approved about a year ago, last June. 14 French delivery system, inline sheath, allows treatment of vessels even 5 millimeters and somewhat less in some patients. Annulus treatment range 18 to 26 with a larger valve that should be coming to market hopefully by the end of the year to allow treatment up to annuluses in 30 plus range, the so-called XL valve. Repositionable, recapturable, so this is the first valve that was commercially approved that has the ability to be deployed up to 80%, and then if you don't like the position, you can adjust it accordingly. More uniform radial force with a little bit longer extension of the sealing skirt to help reduce paravalvular leak rates compared to the initial CoreValve Classic system, and the improved delivery system to allow a more predictable deployment as well. So these are the data that led to the approval of the CoreValve Evolut R valve. 1.3% mortality at 30 days. Once again, tremendous rates of outcomes. The big knock on CoreValve has always been the pacemaker requirement, 20% with CoreValve Classic, and I think with both improvement in the system and improvement in delivery techniques and valve implantation depth and other things, I think the pacemaker rate has gone down pretty significantly, down to 13% in this cohort of patients that led to the Evolut R approval. And moderate PVL for this valve was 8.3%, so pretty good outcomes overall. And this continues to show that with the self-expanding type of valve, the nitinol self-expanding valve of the CoreValve, the PVL rates continue to get better over time. 35% none or trace at 24 hours immediately post-procedure, and at 1 year that number is almost doubled up to 62%. So I think once again showing that with the CoreValve system, the PVL rates continue to get better over time. So these are, of course, the two valves that are commercially available in the United States, but this is a picture of a diagram of all the other available valves. And I've highlighted the 3 valves that are currently under investigation in the United States. You'll hear more about these later today. But we have the direct flow medical valve being studied in high and inoperable risk patients, the Portico, St. Jude Portico valve, and then the Boston Lotus valve. So all 3 of these, I think, have been designed to try to improve the rates of paravalvular leak by allowing a repositionable, recapturable valve. The 2 that are kind of more unique are the Lotus and the direct flow. Direct flow, you can see, looks more like a surgical valve than a transcatheter valve. Really no metal in the system at all. And the Boston valve is sort of a hybrid self-expanding forced expansion valve as well. So I think we'll see what the data comes out on these 2 valves, but I suspect that the early data shows that paravalvular leak rates are almost non-existent, with 85 to 90% of people having none or trace or even mild PVLs. So moving on to the next subset of patients that we currently treat with transcatheter valve treatment is valve-in-valve. So people who have had a previously placed surgical prosthesis that has now failed, tissue valve, high and extreme risk surgical patients, approved for a core valve system in March of 2015, and SAPIEN XT, the second generation SAPIEN system, had approval in October 2015. So once again, I think, for a person who's high or extreme risk and has had a previously placed surgical valve, this is really, I think, the standard of care for those patients as well. So-called off-label indications. What are other people doing these days to manage valvular heart disease with what we have available today? As I mentioned earlier, mitral is still a little bit further away from what we can use mainstream, but we still have a lot of patients with mitral valve regurgitation that wouldn't otherwise, or stenosis, that wouldn't otherwise have a significant option for treatment. So some people are putting in transcatheter aortic valves in the mitral position for a failed biologic mitral valve and someone who's had a previously placed mitral ring annuloplasty. There's also people who have been putting in transcatheter aortic valves in the native mitral position in the setting of severe mitral annular calcification to help sort of anchor in the valve in place, and once again, patients who don't have another option. There's an ongoing, recently ongoing IDE pilot study in the United States that is really aimed at studying the use of these transcatheter aortic valves, the SAPIEN system, in patients with failed bioprosthetic mitral valves or rings, as well as native MAC. And I think this will help answer some questions about whether or not this is a feasible strategy in patients who are higher in inoperable risk for surgery. So I think, various sites have published a series showing that valve-in-valve in the mitral position is certainly feasible, and the outcomes are good in well-selected patients. A 5-year experience from the group in Vancouver early on, showing pretty, very good immediate post-procedure outcomes. I think the tricky part with a lot of this is it's still transapical, and this subject, in this population, is 85% transapical were treated. So it's still, as we know from TAVR, transapical is not ideal, pretty morbid in a lot of patients, but sometimes you don't have another option. You still get good results in those people. The outcomes from that series is you get a reduction mean gradient from 11 to 7. Similarly, for rates of mitral regurgitation post-procedure, all patients had either mild or no PVL. There are places doing non-transapical approach, and I think more recently. Transeptal has become, so femoral venous transeptal approach to put the transcatheter valve in the mitral position is being done more readily now than it was in the earlier series. But I think still the bulk of cases are being done transapically. This is from the Valve-in-Valve Global Registry that shows about 12% were being done transeptally in this cohort of patients, whereas most, still 84% or so, were done transapically, some direct left atrial access. And then this is another series from the Mayo Clinic of 4 patients that once again showing that transvenous transeptal approach is feasible and doable. Certainly some differences in deployment and positioning of the valve, but doable if you have a patient that you really want to avoid transapical access in. So I mentioned the so-called valve-in-MAC, TAVR valves in native mitral annular calcification. So this was recent data that was presented at the Euro-PCR meeting last month. It's 104 patients from 47 centers in 11 countries, spanning about 3.5 years. They underwent TMVR with compassionate use of the aortic transcatheter valve that was available. Most of these were the SAPIEN XT and SAPIEN 3 system. A few Lotus and a direct flow here on the left. The SAPIENs were obviously some of the earlier ones that were available before XT and S3 were available. And here I think the interesting thing is a lot less transapical doing it this way, about 45% transapical and 35% transeptal. So I think maybe showing that some places are becoming more comfortable with the transeptal approach, and I think it still will have the same challenges in terms of the delivery and stability, but a system like the S3 that has a lot more stability, that you can get more of a coaxial alignment with the valve, may be more advantageous than some of the earlier valves for going transeptally. And this modified transeptal approach, which extruding the wire from the left ventricular apex percutaneously out and snaring it through a sheath to help stabilize the delivery system. Some places, like at Henry Ford, it's one of the places that are sort of pioneering that technique. So I think this once again shows that it's a feasible option in a lot of patients, and if you have a good procedural result, you can have a good outcome. Mean pre-procedure gradient 11.5 millimeters mercury down to 4. I think the caveat to this was 75% technical success rate, so that's 1 out of 4 failure rate. 30-day mortality 25%. So a lot of these patients are very sick, and that's why they're getting this done under compassionate use criteria. But certainly these data tend to mirror, I think, the early experience with transcatheter aortic valves. And some of it is, I think, learning curve, and some of it is the technology limitations for treating the mitral valve with a aortic valve, a stented aortic valve prosthesis. The big issue, I think, that we still need to work on in terms of coming up with a mitral valve that's going to work is dealing with left ventricular outflow tract obstruction, either by the stent frame itself or the native anterior leaflet that then gets pushed up towards the outflow tract. 10%, and a lot of times this is, most times this is hemodynamically significant, and a lot of times fatal. Most of the mortalities, the cardiovascular mortalities in this series, were related to left ventricular outflow tract obstruction after valve deployment. So some of the challenges, I mentioned the steep learning curve. You still have to do transapical in a number of people. The left ventricular outflow tract obstruction, how do we predict that? I mean, what ways can we use CT and other things to help predict which patients are at risk for left ventricular outflow tract obstruction with this strategy? Annulus sizing methods. It's, you look at all of these things, it's the same issues that we dealt with with the early onset of TAVR. So I think we're learning some from the experiences that we had with TAVR and not making all the same mistakes, but it's a completely different valve with different anatomical considerations that has affected our ability to manage treating this valve process with available transcatheter aortic valves. And similarly, I think, which we all struggle with at times, is patient selection. We always want to help all the patients that we see, but there are some that, in that cohort C, if 30-day mortality in your study is 25%. There's probably a fair number of patients in there that in the future we need to have better ways to select out to make sure that we're not going to offer treatment to people where it's futile and their short-term morbidity and mortality, even regardless of a successful procedure, is going to be high. These are some of the anatomical, I think, limitations that have slowed the transcatheter mitral valve arena. As you'll hear later today from Dr. Wong, and I'll allude to in some of my talk later, is that there's a lot of valves out there that are being investigated in different ways to help manage or treat mitral valve regurgitation by a transcatheter approach. And I mean, these are some of the issues that we come up with. The different shape of the mitral valve compared to the aortic valve, the interaction with the subvalvular apparatus and the left ventricular outflow tract, as well as the aortic valve. And it is a larger valve size, so requiring a larger prosthesis, a lot of times being transapical. If you're having to go 24, 28, 32 French transapical to get a valve that's a suitable size, then I think once again it's going to limit our abilities to treat these patients with improved outcomes long term. So moving on to, I think, a nice segue to what we have available for mitral valve repair currently. So transcatheter mitral valve repair, really the only approved device right now is the MitraClip. This was approved in October of 2013 for treating patients that are so-called prohibitive risk for surgical mitral valve repair or replacement. This is the MitraClip delivery system. Sits on a stand, goes transfemoral venous, 24 French across the femoral venous access, 22 French across the intraatrial septum, from femoral venous approach transeptal to approach the LV. Has these arms that are opened up, used to grasp the leaflets and find the area where the coaptation is awry and really try to hone in on the pathology. And this procedure, as I alluded to earlier, is completely driven by transesophageal echocardiographic imaging. So once again, I think identifying the role of the heart team and have imaging specialists that work closely with you, and the involvement of 3D echocardiographic imaging, I think, has helped expedite and make this procedure more efficient as well. So as I mentioned, this was approved in October 2013 commercially. This is data that was published from the Transcatheter Valve Treatment Registry earlier this year, looking at the initial commercial experience, 30-day outcomes. Severe mitral valve regurgitation in 80% of the patients that were treated, grade 1 or grade 2 residual MR in 90+% of the patients. So this is even better than what was in the Everest 2 registry and even the high risk that led to the approval of the device. Very reasonable outcomes as well, once again in a prohibitive risk population. 30-day outcomes, 5.8% in terms of mortality. Stroke rates are pretty low. Major bleeding, less than what was in Everest as well. Low in-hospital mortality for this patient population. So overall, I think good experience showing that this technology was able to be introduced commercially with favorable outcomes. This is data that came from Duke, published last year as well. This is looking at patients from the MitraClip trials, Everest and high-risk patients in that group, propensity matched to patients in the Duke Databank of Cardiovascular Disease with also in the Duke Echo database with also severe mitral valve regurgitation that received just medical therapy. So I think showing that MitraClip not only does have an impact on symptomatic relief, but also has some more survival outcome as well. These patients, if you can get a good outcome in terms of mitral valve regurgitation reduction at the end of the case, I think overall these patients are still well served. So this was good data to have to support the use of this system in prohibitive risk patients. So a little segue to paravalvular leak closure. This is something that a lot of places do now, once again in patients that are high risk or inoperable, who've had previously placed either mechanical or tissue valves. Anywhere the incidence ranges from anywhere to 5 to 17%, more common in the mitral position than the aortic position. But once again, a lot of people who have gone through a sternotomy and recovery once before and are now 80 or 75 with multiple comorbidities have the potential to at least be treated with a less invasive approach. The difficulty with treating these patients is that the defects are often oddly shaped, and really none of the available plugs or closure devices are obviously designed for this, and so getting complete closure I think is not usually the case, but oftentimes if a person is transfusion dependent because of hemolysis related to the paravalvular leak, you can often reduce that. And similarly, if you reduce the leak, they can have a significant improvement in heart failure symptoms as well. So not a perfect approach by any means, but certainly an option for people who don't have another good surgical option. And this is another procedure that highlights the advantage of having 3D transesophageal echocardiographic imaging to help support the procedure and guide the procedure. This is older data from 2011 that I think just shows the feasibility, and 57% of patients treated, 86% success rate, overall freedom of survival that was pretty good overall, and once again mitral was more than aortic. So a little bit on left atrial appendage occlusion. I think I mentioned that this is something now that we work together with our electrophysiology colleagues to treat patients with atrial fibrillation who aren't great long-term candidates for oral anticoagulation, with an option to exclude the left atrial appendage percutaneously. The Watchman device is currently the only approved device in the United States to do so, approved last March. Recently has a national coverage determination as of February to help allow the treatment of patients with non-valvular AFib who aren't great candidates for long-term oral anticoagulation. Overall, similar reduction in terms of risk of ischemic events compared to warfarin. All-cause death, a little bit less. This is a meta-analysis of all the Watchman data that led to its approval, and I think that the big advantage is long-term patients aren't on warfarin, and so their risk of major bleeding that wasn't related to the procedure itself goes down significantly. So I think it's a second line treatment option for patients who aren't great candidates for long-term oral anticoagulation. And just to give you an idea, similar to transcatheter aortic and mitral valve, I mean, there are other left atrial appendage occlusion devices that are out there being studied now that will be coming to market in the next few years. The Lariat is a system that got a FDA approval not for treatment of AFib, but for another indication, as it's a suture ligation system, but was being used for AFib, and it's, I think, sort of gone down a little bit in terms of popularity nationwide because of some increased adverse outcomes during the procedure. So I think we need to study this more, and it's currently being studied more for this indication so that we have a better idea of what the safety profile is before it gets used widespread. So congenital heart disease, Dr. Harrison's been treating ASDs here for a number of years now percutaneously, and I think these are the two main devices that are the mainstay of treatment of secundum ASDs percutaneously. This is the Amplatz ASO device, comes in various sizes up to 38 millimeters, treats a lot of patients. And then the more recently approved second generation Gore system, Gore cardioform septal occluder. Dr. Krasuski is going to talk about this a little bit later today, but this was approved last summer as well. So another improvement in technology that's allowed for our treatment of patients with adult congenital heart disease with atrial septal defects. PFO, a lot of you may have heard recently, it's back on, I think, getting closer to having an FDA-approved indication, hopefully, for treatment of patients with an occluder device with recurrent cryptogenic stroke. This is the Amplatz PFO occluder. This is what was recently reviewed by the FDA panel, again, after having longer-term follow-up from the RESPECT trial that initially did not meet its primary endpoint. But I think in patients that have cryptogenic stroke that are certainly young, they benefit from PFO closure in that population, and hopefully this will lead to an FDA indication in the near future for that device. This is that Gore cardioform septal occluder, much more reliable delivery system, you could say, than the previous generation Gore device. Comes in 4 sizes up to 30 millimeters. So used currently now off-label for PFO closure, but it is being studied in the REDUCE trial for cryptogenic stroke, with data to probably be presented in 2 years, and we'll once again see if it has a role and gets an approval for PFO closure for cryptogenic stroke. So the 2 ways we're treating right ventricular outflow tract pulmonic valve insufficiency in patients with congenital heart disease previously repaired. The Melody valve, 2 sizes available, Medtronic Melody valve, the SAPIEN XT system. They were both studied and have good outcomes in those patients. And SAPIEN 3 system is currently being investigated to be able to be used in that setting as well. So I tried to give you a broad overview of what structural heart disease treatment is today, and what all of the things we have in our armamentarium to treat patients. And as you'll see, I think a lot of the focus in the next 5 years is the other valves and what we can do to improve TAVR treatment moving forward. So in 5 years from now, what about for TAVR? What do we think TAVR is going to look like? Expanded indications, intermediate risk. That data from Partner 2A was recently presented at ACC this year. Will there be an expanded indication for treatment of intermediate risk patients in the next year? It looks like that will be the case. Most likely. SIRTAVI data from that, the core valve study, looking at intermediate risk patients as well. Will this become the new standard in treatment of intermediate risk patients? I think most patients, if they know it's an option and you have equivalent data, they're certainly going to select the less invasive option. Now even more, moving more down on the low risk spectrum, STS risk less than 3%. So patients that do very well with surgical aortic valve replacement. The bread and butter of surgical aortic valve replacement, patients do really well, 1 to 2% 30-day mortality. How's TAVR going to do in that population? So we have the Partner 3 and then the low risk core valve study that have just begun enrollment, and so we'll see in a few years what these outcomes look like in low risk populations and how will it look. I think the interesting thing is, we have the SAPIEN 3 system and the core valve system that are going to be studied in those populations, but then we have these newer valves that are being investigated in high and inoperable risk patients that were mainly aimed to help improve and become more comparable to the rates of PVL with surgical aortic valve replacement. So how do these systems move in the next 5 years? The direct flow, the Lotus, the Portico, how are they going to get incorporated after results of their US IDE trials come out? And I think the important thing, once again, when you're moving to a low-risk population is, if low-risk surgical AVR has a less than 5% pacemaker rate, then I think TAVR valves really need to be close to that. If you're talking about anybody over the age of 65, a 70-year-old who's previously healthy, who could be expected to live another 15 to 20 years with a surgically placed valve, I think you got to worry a little bit in having pacemaker rates in the 10 to 15% range. I think commercially we'll see what SAPIEN 3 and core valve Evolute R look like in terms of their permanent pacemaker rates, but once again, another thing to think of before this treatment gets completely expanded out to lower risk patients. Do we worry at all about TAVR durability? And this is something that got really a lot of press at EuroPCR as well. Initially all of the valve function up to 5 years looked really good, and there wasn't any evidence of significant deterioration in valve function in a lot of patients that got treated with transcatheter valves in the PARTNER study. This is one of the first looking back at 10 years out, so patients that were treated from 2006 to 2010 with mostly the early generation SAPIEN systems. The second generation SAPIEN system XT only in 37% of people, but it's a little troubling to see this all of a sudden right around 5.5 years, the valves seem to deteriorate pretty significantly. Now why this is, and is this relevant today? It's hard to know. These valves are, the way we size them, the way we implant them, the delivery systems themselves are very different than the early experience. So whether or not that has some impact on long-term valve degeneration it's hard to know, but I think certainly some sobering long-term data that maybe give us a little bit of pause before we expand the use of transcatheter valve technology in low-risk populations. I think for a Carpentier-Edwards valve that's implanted surgically, 15 to 20 years is probably what you can expect to have as terms of valve function and freedom from degeneration on average. And so I think low-risk patients should have at least that. What about all the issues that we've seen recently in the last couple of years about subclinical leaflet thrombosis or valve thrombosis in transcatheter aortic valves? Maybe as high as 5% incidence. Is this another thing that we need to worry about more so? Is this something that's being studied more now in some of the newer trials that are going on? They're embedding CT into the trials to really study this aspect of transcatheter valve treatment for aortic stenosis. Are these patients going to have to be on warfarin for some period of time after insertion of the transcatheter valve? A lot of questions I think that have come up now that the technology is being used more broadly that I think we just need to think about a little bit more before this procedure gets introduced into lower risk patients. So segueing now to the mitral valve, once again, transcatheter repair options. I mean, this is a long list of the repair options that range from MitraClip, which was approved already, a lot of chordal repair type systems, a lot of annuloplasty type repair systems. But I think the reason we haven't seen anything come out yet with the mitral other than the MitraClip is that it just goes to show how complex both the anatomy of the mitral valve and the pathology of the mitral valve that occurs. It's usually not just a leaflet problem, or not just an annular problem, or not just an LV problem. It's often a mixture of all of the above, which tends to complicate, I think, finding one relatively easy, less invasive transcatheter approach to treating this, this pathology. But just to give you an idea of all the different mitral repairs that are mitral repair systems that are currently being investigated. I mentioned these anatomical limitations, and I think they're important because similarly for replacement, look at all the various options that are currently being studied for transcatheter mitral valve replacement. All of the larger companies have sort of invested in all of these smaller companies to see which one is going to play out, and a fair number of these are currently being investigated to see if they're going to be reasonable options for transcatheter mitral valve replacement. But most of them, once again, are transapically placed. So I think a lot of the limitation with the TMVR is going to be the fact that most of it's still going to have to be transapical at this point. What about the forgotten valve? So the forgotten valve I call is, of course, the tricuspid valve. So, I mean, a lot of patients end up with severe tricuspid regurgitation, and oftentimes if they're going to get another valve surgery and they have coexistent severe TR, they may get a ring placed in the tricuspid position or hope that the tricuspid improves after you fix the left-sided valve disease. But these are some of the current ongoing first-in-man and limited IDE trials that are going on with various tricuspid systems. So the mitral line was actually, as by the name would say, was designed for the mitral valve, but is being used for tricuspid as well. There's a handful of centers in the United States now that are participating in using this system. What it is, it's placing these pledgets percutaneously through a venous approach and essentially creating, eliminating the posterior leaflet of the tricuspid valve, creating more of a bicommissural, similar to what you have with the mitral, to reduce the annular size of the system. And this is another procedure that is very, very dependent on 3D transesophageal imaging to both deploy and assess success of the procedure. Another system, this tricuspid repair system that acts as a spacer. It occupies some of the space in the regurgitant orifice area of the tricuspid valve to help reduce tricuspid insufficiency. Another thing called the tri-cinch, certainly being studied as well. Going up from the IVC approach, trying to cinch down the annulus and then placing a stent in the IVC once you have enough tension on the annulus to help reduce the TR. All of these things are coming out, and this doesn't even go into some of the off-label things that are being used for transcatheter treatment of tricuspid valve regurgitation, such as placing TAVR valves in the IVC inside a stent to help reduce regurgitation to the lower body and to the liver. So, I think what I've tried to highlight is, what structural heart disease and treating structural heart disease is really focusing, I think, on optimizing patient care and outcomes, and it's really the heart team approach and this spectrum of tailoring the approach and the best option for each individual patient. We're really fortunate to have the improvements in technology that we've had in the last 5 to 10 years to offer people, hybrid approaches to treating valvular heart disease and structural heart disease in general. But I think we still lean on our surgical colleagues a lot because they've gotten much better too in terms of less invasive surgical options, thoracotomies and other things, small sternotomies that have improved patient outcomes as well. And surgery still works very well for the vast majority of people. That being said, I think the true advantage in structural heart disease today is incorporating this heart team and really leveraging everybody's experience and abilities to come up with the best approach for each patient. So lastly, I just wanted to give you a little bit about my experience in New Mexico. As Dr. Hughes mentioned, I went out to Albuquerque last year after I finished my training here at Duke, and really the main reason I went out there is it's an area that's a big state, but very sparsely populated and underserved medically. So here's Albuquerque, where this red star is. This is a sort of a population density color-coded map. Whole population of New Mexico as of the 2010 census was about 2.1 million. Close to 700,000 of the patients live in this area. Another 100,000 live down here. This is Las Cruces. El Paso is right across the border here in Texas. And then another, 50,000 or so up here in the Four Corners region. The rest of the state, as you can see, is all small cities, less than 25,000 for the most part, all sparsely populated. And Albuquerque is sort of in the middle of the state. It's 2 to 3 hours from any real corner that you try to go to. A lot of people on the eastern part of the state will go to Lubbock and Texas for treatment just because it's closer. I would say few people go to Arizona for treatment, but some still do. Some people from the northern part of the state will go up to Colorado. Denver's, about 460 miles from Albuquerque. So, I think that was one of the main reasons I went out there. Is it was an advantage and an opportunity to provide a novel therapy, a novel treatment approach to a much-needed population. So I don't know if any of you have been to Albuquerque, New Mexico, or New Mexico in general, but I would say the one thing that Albuquerque is most known for is the International Balloon Fiesta that occurs every October. So if you happen to come to Albuquerque in the first 2 weeks of October, this is what the sky looks like every morning at about 7 o'clock. So, hundreds and hundreds of hot air balloons filling the sky. It's a pretty cool scene, when you go out there, and it draws a lot of people from all over. The other thing that Albuquerque is known for is the Sandia Mountains. So Sandia, for people who speak Spanish, is watermelon. So at sunset, the mountain turns pink like this. If you get it, and so that's how it got its name, was pink for watermelon. So it's a nice scene every time you drive home up to the mountains towards the end of the evening. That's what you get to look at, which is pretty cool. So I mentioned the closest city is Phoenix, about 430 miles away, Denver 460 miles away. So for most patients, and New Mexico, in addition to being a sparsely populated state, is a very poor state. So a lot of patients don't have resources to really go out of state for health care. A lot of Native American reservations as well that once again seek their health care in Albuquerque. So the opportunities for treating patients with cardiovascular disease in Albuquerque are vast. And I would say in my first 6 months there, the complexity of the coronary disease, the valvular disease, was just incredible. I mean, on par with what I was seeing here, and more so because people presented so much later into their disease processes. And so it was sobering to see the degree. There's one of my nurse practitioners says, Albuquerque, New Mexico, he describes New Mexico as this, that Albuquerque is a middle-sized city surrounded by third world. And that's pretty appropriate. You see these patients come in and you realize, a lot of the ones that live on the reservations, don't have running water and things like that. So it's a different place, but I think a lot of opportunity as you'll see. So when I got there, they had started the TAVR program in December of 2013. 90 cases in 2015, so we did about 50 from when I started in August to December. It's a really vibrant, growing program, very high volume surgical program. Once again, I think other than CABG in Las Cruces, none of the valvular treatment gets done anywhere else outside of Albuquerque. There's a couple other hospitals in Albuquerque that do, high-risk CABG or valve cases, but I would say the vast majority have been done at Presbyterian for the number of years. As was mentioned to you earlier, I had the opportunity to help start the MitraClip program, and I've been very successful thus far. Started in January, so within 6 months of arrival, started the MitraClip program, and once again, the only program in the state. Just the other day, I had a patient that was on their way to Tucson, and they had a family member who knew somebody who got their MitraClip done in Albuquerque. They said, "No, why don't you just go up to Albuquerque to get it done?" So a nice other opportunity. And in fact, I had an insurance. One patient was all set to get his MitraClip done at Mayo, and then the insurance called back and said, "No, Albuquerque has a program. No, go see Dr. Halim." So we're getting referrals from everywhere now, which is great. We have our Watchman program that's starting this month as well, and fortunate enough to be selected as a site for the SALIS trial investigating direct flow medical valve as high and extreme risk patients. So I think just to show you a little bit of what we've been trying to do and what we're doing at Presbyterian in Albuquerque and help growing the program. Some of the important things to consider that I faced at a medium-sized hospital at Presbyterian was how do you do this? As a lot of people in the room know, structural heart disease treatment doesn't make money for the hospital. It doesn't make a lot of money at all. In fact, some procedures lose money. So how do you get administrative support for something like that? And I think what we've been able to try to focus on is that you're already the center of excellence when it comes to surgical heart disease. So why not complement that with becoming the center of excellence and structural heart disease more broadly, including transcatheter valve treatment. they've really latched onto that idea, and quite frankly, you tell them if they don't get it here, they're going to go out of state to get it. And Presbyterian also has a health plan, so they're going to pay out of state to get it if the patients need it. So we've been able to get them on board to help say, well, we want to do these things here, and we have the opportunity and ability to do all these things here, so let's take advantage of it. I think volume is obviously key. You know, if you have a vibrant referral base and surgical program and everything else, the structural program goes along with it. And we've seen that in Albuquerque, obviously seen that here at Duke as well. The so-called halo effect, I think, still exists to some degree, but as technology continues to improve with mitral and TAVR and everything else, and moving towards lower risk patients, I think you have to have a good base of patients. And we're well positioned to, as I mentioned, the only main surgical center in or structural heart center in the state. So another key aspect, and this really where you lean on your awesome valve clinic coordinators, is really working on referrals and communication and getting patients expedited quickly. So from referral to treatment, really within a month, I think is the goal. If you're delaying much more than that, if people have other options and referrers have other options, they'll probably end up going to their other options. So making that important. And the finances, as I mentioned, I think you have to at least optimize what you can, and a lot of that is working with your hospital billers and coders and making sure that at least you're maximizing what you should be getting reimbursed for these procedures that are being done commercially. And marketing, when I first got to New Mexico, I took 3 trips within the first 3 months out to Las Cruces and Farmington, which is in the northwest part of the state, and visiting with various doctors and everything else, and just building the program. I think that's how you do it. You go meet people and you let them know what you have and what's an option. And doc I spoke to in El Paso last week, who sent me the MitraClip patient, he had no idea that we were doing TAVR in Albuquerque, and I don't know where his patients were going, Houston or Dallas, which is much further away. And so I think once again, just being more vocal and letting people know that we're there and we have a vibrant, growing program and we can treat our patients well there. So that's pretty much everything I have to say this morning. A definitely special thank you to Kevin Harrison and Chad Hughes for inviting me to speak here today. It's a real honor to be back and have the opportunity to talk to you all as the keynote speaker. Special thanks to my family. None of this would be possible without them. My wife's not in the picture because she's always taking the pictures while I'm at work and sending me the pictures, but we have our 2-year-old daughter, Serena, and our 4-month-old son, Ryan, who was born this year. And I just want to thank you all.